Good morning, shalom. Good morning, sabah al-khair. I'm absolutely honored and privileged to be here. Hagai, thank you very much for this invitation. I honestly, over the last few days, I feel I'm at home. I'm originally from Baghdad, Iraq, but I've been in England for 30 years. And I connected with some of friends and colleagues from here, and I honestly feel I am at home. So thank you for your generosity. Thank you for your welcoming. And this is going to be a start. I would like to extend my arm all the way from London, from our center, to welcoming fellows. And if you are a consultant, you like to stop by and see what we are doing. And we have a very, very big, ambitious plan with King's College London to take some postdoctorate, and we love to collaborate with you. Hagai spent a year with us, and it was absolutely great. We got so many ideas together, and I'm really, really keen to get some of enthusiastic, young pain physician to join our big center. So I've been asked to talk about neuromodulation. This is what we have been doing for the last 30 years. And things has changed over the last 10 years from the way we used to do. And I'm going to give you what up-to-date research in our department. And this is my disclosure. I don't work with any company and as an advisor, but I work with them for research. So any of the talk is not intended to promote commercial therapies at all. And we have a rather big center. We are separated at two sites, St. Thomas's, that looks at the House of Parliament. That's where office is located. And we do the implants at Guy's Hospital, which is near London Bridge. And you can see here, this is right here, King's College Medical School, and we are affiliated with King's College Wolfson Center with the Steve McMahon Group, and we have very ambitious plan looking into biomarkers by taking CSF from these patients, and we measure fractional RNA. We are working on neuroimaging to measure translocator protein. This is the sexy new way of phenotyping these complex patients. We have a rather big department. We are 85, and we keep expanding. We don't know where we're going to put them. Every time we just keep bringing consultants, nurses, psychologists, physiotherapists, occupational health. We are very well known into the neuromodulation therapy, as well as we are doing the cognitive behavioral therapy and anything in between, anything in A to Z, interventional therapy. We have residential pain management program for 3 weeks. The patient stayed with us to help them from physical and psychological part. So, and we are now using all this expertise to 2 weeks of program. We call it a pre-implant program. We rehabilitate the patient before even we do a trial of spinal cord stimulation, because our patients comes with a lot of issues, and we need to optimize their condition before even we do a trial. And a lot of this coming in the next session by my colleague, David Pang. So catch-up areas in our hospital from around the country, including Channel Islands. We see about 4,500 to 5,000 new patients. And we implant as just over 200, and we do surgeries, different of surgery, about 600 surgeries a year. And we have very proactive research group, which all is self-funded from the research that we do. And we are running a number of initiatives, not only neuromodulation, but interventions, pharmaceutical therapies, basic science, and a couple of postdoctorate working with us on CSF, etc. So always one of the mission is to education and expand our knowledge and information and experience to the rest of the world. So we do live procedure, workshops, and this is one of the events which we done just a few years ago. We done a number of implants live, and there was a discussion between the attendees as well as the operator. We do workshop, cadaver workshop, that's every year. And the next one is going to be July 2nd, 3rd, and 4th, and welcoming you to join us. And now we go to our talk. That's the overview of my talk. We're going to talk a little bit of the introduction of the stimulation and patient experience on the conventional spinal cord stimulation called paresthesia. And we move on about this new therapy and a new concept, HF10 therapy, as well as burst stimulation. So this is the definition of a neuromodulation for those who not practicing neuromodulation. It's not distractive. We neuromodulate. If the nerves overactive or underactive, we apply electricity or chemically, and we change the function back to normality. And broadly speaking, it's fair to sub-classify them to electrical, that's in form of spinal cord stimulation, and chemical for intrathecal drug delivery system, which we can put morphine, baclofen for spasticity. So this is the way we neuromodulate the condition of the patient. Now, over the last few years, a new generation of spinal cord stimulation arises called paresthesia-free. And compare it, there is no buzzing sensation at all. It works completely different from the conventional spinal cord stimulation where you feel paresthesia over the pain, where the pain is, and that's counter-irritate the pain. And the patient, instead of feeling pain, they're feeling paresthesia. And so these are the two therapies, 10 kilohertz, and the other one called burst stimulation. And now just looking into why people coming off conventional spinal cord stimulation, where's the issue? We've done it for years, and it does work for leg pain, but it never worked for the back pain. And the other issue is paresthesia. This buzzing sensation, a lot of people don't like it, and stop them from keep it on all the time, and stop them from driving, stop them from doing things. And over the years, all these companies invested a lot of money to enhance the paresthesia, but it never thought about how can we make it better to get pain management of the back. So there is two major studies, one by Rick North and Krishna Kumar. Both of these RCTs looked into management of failed back surgery syndrome with the leg predominant pain. It worked very well for leg pain, but never worked for back pain. And hence, there is other companies thought about to come with a new waveform to help with these conditions. So do they actually pay our patient like paresthesia? These are different studies being done over the time. This is before the launch of Medtronic study about called adapter stimulation. You can see significant patients find that it's not comfortable. Kapural study, that's a census study, looked into whether the patients like it or not. They found that it's comfortable or not. A lot of patients on the arm of paresthesia therapy found it at least 50% not comfortable. And Jeff TD, that's a small group of patients, looked at the patients that they asked them whether they prefer paresthesia-free or not. And you can see a lot of them prefer paresthesia-free therapy. And now, one of the questions is, do they actually work for back pain? And this is the summary of all the study of paresthesia-free devices. Nevro, Abbott, Boston Scientific, and Medtronic, these are four major companies who produce these therapies. Two studies, that's from Nevro and Abbott, RCT, and it's clearly demonstrating that it is actually effective for back pain, as there's no shadow of that, especially for failed back surgery syndrome. One characteristic about neurotherapy, it has paresthesia-free as well as paresthesia-independent. It means independent that you don't need to wake up the patient in the middle of the operating theater and map where the pain is. And that's the beauty about it. So patient is asleep comfortably, and then you put the lead at T9, T10, and you finish you don't need to wake up the patient. And we will touch base on this. So this is what is consisting of exactly similar. It is implanted pulse generator, exactly similar to the wire that the leads connected. And it has a patient has a remote control, can adjust the stimulation, as well as it can move the two contact, give them three choices, and it can choose between different contacts. So that is, and it is the patient, technically we put the patients here, that's we called it the golden disc, T9, T10, and we stagger two leads. And nowadays we use even one lead because we don't need two leads. So we started 2009 with the high frequency stimulation. It was the first big European study. But prior to that, it was just a proof of concept on trial. There was no implanted because FDA did not give Nevro to implant the patients with IPGs. So that's a trial, biggie bag on Medtronic leads, and they found it actually effective compared with paresthesia-induced Medtronic. And then our European study, this joint work between us and Brussels from my friend Jean-Pierre Van Buiten, and 2 years follow-up, sustainable, good back pain relief. And then this is called the SENSA study. It is 200 patients. One arm is HF10 therapy, and the other arm is paresthesia. It was Boston Scientific, and it's consistently over 2 years produced good pain relief in the back compared with paresthesia. But one of the things here, all these patients, majority of them, even in our European study, they are failed back surgery syndrome. And there was discussion right from the outset in our department. If it is so good, why don't we use it before even patient having spinal surgery? Why did the patient undergo unnecessary surgery? And then they have a failed back and they come to us to do the stimulation. Shall we stop using the therapy as rescue therapy and we use it as a primary therapy? So on the back of this, we done this, what we call it, virgin back study. That's proof of concept, small group of patient who never had surgery before. And it was the work with our spinal center. It is published for this is 3 years data. And it was collaboration between our center in pain as well as the spine center. So they selected the patient for us. And we reviewed them very carefully and we selected to ensure there is no surgical remedy for their pain. There is no grade 3 spondylolisthesis. There is no nice, juicy, big disc causing trouble for them. So those patients superly selected. And we'll show you how much an effort to get these patients. So we looked into different outcomes, and every patient underwent plain X-ray in flexion and extension to exclude spinal instability, and each patient underwent MRI scan. And these scans reviewed by a neuroradiologist, and he looked into whether if there's a Pifferman classification and assess the degree of degradation within the discs. And as you might know, Pifferman classification graded from 1 to 5. 1 is a small degeneration until 5 is bone on bone. And this is the outcome from the MRI scan. All of our patients have some form of degeneration disease, and some of them have modic changes and high density zone. Some of this patient, when the surgeon offered them spinal surgery, informal spinal fusion and disc replacement, they refused. They said, no, this is major surgery for us. Is there anything else? And they said, yeah, as a matter of fact, there is an ongoing study called spinal cord stimulation. So potentially some of the patients could have went to have a spine surgery. But we were having the study, and we offered them the therapy. And this is the outcome. We started when we reviewed 77 patients, 98 patients. We enrolled 21. One failed the trial. At 12 months, we kept the 20 patients. 24 months, 2 patients out of the study. 1 died unrelated to the therapy, and 1 explanted because no benefit from it. And by 36 months, 1 is lost in follow-up. So looking into that significant, and that's the trial, 95% successful trial. But remember, super selection of the patient, and this is the key for neuromodulation. Okay, still selection of the patient, no matter what we are going to improve in technology. And this is the outcome, 3 years. This is 2 graphs in one. One on the right-hand side, from 60 to 0, this is Osweiser Disability Index, starting from nearly here, about 58, and dropped by 36 to 25. Significant reduction, improvement in their disability following the stimulation. And if you look, the intensity of pain, nearly 80 to 10 after 36 months. And that's the beauty about this therapy, consistent outcome. When you select the patient, this is what you get. When you look into the leg pain, intensity is reduced. To start, what was not major issue, but it is even with the leg pain has improved as well. So, and this is what we are really proud of, bringing patients back to work. And that is major issue, is improving the whole family income. So you stop the patient, asking for disability benefit. The family is happy, the wife is happy, the friends are happy. So that's very important, looking into bringing patient back to work, and we managed to do so. Major issue in the western part of the world, using opioid. And look how many patients before we start the stimulation and after 36. Significant reduction of people using opioid. Not only opioid, but other therapies, including anticonvulsant therapy. And patient satisfaction, PGIC, patient global impression of change, significant improvement. And this is the side effect, hardly any. Just pain at the site of the implant, we change the position, has improved. So from this, is clearly that is the therapy work on the patient who never had surgery before. It is reduce opioid, improvement in their function, and return back to work with minimal side effect. Among you now said, oh wow, this is too good to be true. And this is open label, and this is, there's a lot of observational bias, and there could be company bias. So there is so many issues, and I agree with you. This is a proof of concept, only 21 patients. But this is a first step toward to build up for the biggest ever RCT, which never been done before, randomized, controlled, sham-controlled, double-blind study. So, but we found that it worked. It said there is no excuse. We need to do this. Obviously, the company is shying away from this, but we have a few problems. Number one, we don't know how big the placebo effect among all these patients, and we need to figure it out. So we had the frequency study. This is one of the just recently published study in New York Academy of Science. We got all the patients that we done for census study and European study, and see number of patients who reduce opioid. Just to demonstrate that this therapy, neuromodulation, can actually spare opioid. And the other thing that we looked into that there is for virgin back, compared with Sensa patient, there's about 15 patients in European, there's no difference, exactly the same outcome. So the therapy can work for people who never had surgery before. Now, we wanted to find out how big the placebo effect. Nevro was produced high frequency, we refused to do this. But Medtronic kindly said, we can give you the device which is capable to degrade itself internally, so when you put it in a sham mode. So we compare 1,000, 3,000, and 6,000 and a sham. So each patient had to, for 3 weeks on each frequency, including the sham. And this is the outcome. Clearly that it was the sham 25% better, 30% better than the baseline measurement. So it reduces significantly. But what we found is the 6,000 is better than the sham and the 1,000 and the 3,000. So out of this study, we learned two things. The sham is powerful, is about 30%. And we know that the other things we learned that the higher the frequency is the better the outcome. So we know calculation, how can we calculate the effect of the sample size when it comes to the study. But one more thing we done before we submitted, to the ethical committee. The patient, when you put randomized controlled double-blind study, and if the patient on the sham, and we think that it's not going to be benefit, the patient will come backward, forward for reprogramming. And that will result in bias. And patient will definitely not be a proper study. So we created a new form of stimulation called sequential stimulation. So, or cascade stimulation. So normally we stimulate two contacts around T9, T10, either above it or below it, because that's what we call the sweet spot. We put at 10,000 hertz and it worked beautifully there. It's not an issue. But we said, why don't we do sequential? We look into the whole lead activated. 5 seconds on in each contact, and it move to the second set, and the third, and the fourth, and we start again. So the whole cycle about 20 seconds. And in this way, we are actually not stimulating the sweet spot, but a strip of a stimulation. And that's what was the beauty about what we are doing. Preventing habituation and tolerance, because if you beat stimulation on two contact all the time, patient will get tolerance. And we were discussing with some colleague last night, and they saying we are getting, even paresthesia-free, declining in the outcome with it as the time goes by. After 6 months and 9 months, patient outcome is getting less and less, because the central nervous system is very smart, and it's trying to find a way around the contacts of the stimulation. So hence, we are going to do a strip of stimulation. It does not give it this time to habituate and preventing this tolerance. But most importantly, stopping patient bringing back to work, bringing back to clinic to reprogramming. And that's what the methodology, it is open label. We looked into for 2 years, and we number of patients, nearly about 100 patients. And this is demographic data which we looked into. Some patients had 1 lead, some people had 2 leads. Majority of them are back predominant pain. And looking at the outcome at 6 months, as well as the last follow-up. The good outcome improvement by at least 2 points, and with PGIC, good or very good. So for both back and leg pain, a significant improvement using the cascade. Because once you do a study, a major study, people will hold you and find out a hold in your study. It has to be a watertight. So we examined every aspect of it. Now, and this is tornado graph showing like the blue at the back pain is 76% improvement, very little improvement. Even with the little, we're talking even 40%, we say non-responders. It has to be over 50% responders. And this is for the leg pain, similar good outcome. And high patient satisfaction with this kind of a programming. We have some morbidity, some people having pain at the side of the implant, doing changes, but what we notice, there is currently only two explantation, and that's for 2 years. And this speaks volume. It means that the gasket on sequential programming has some benefit of stopping from patient's tolerance. Now, so we got the proof of concept, the virgin back study. We know the power of the placebo. We know we have how to program these patients. And we went to NHR and we got an independent a grant to do a modulated study. So this is multi-center, double-blind, randomized, sham-controlled trial of 10 kilohertz frequency spinal cord stimulation for chronic neuropathic lower back pain. This is truly the first non-commercial sham-controlled SCS. Nevro never want to entertain this idea. They said, no way we will let you do this. Not for your academic curiosity, we are going to wipe away $2.4 billion. So, and one has to understand, because if this study come negative, that means the end of 10,000 hertz. So the only way is to go to have independent from the government grant to do this study. So this is a multi-center study, and we are in the middle of it at the moment. We are recruiting. That's the primary objective, to see how that the patient intervention control after 6 months. And there is secondary objective, obviously, nucleic ODI, return to work, etc., measuring complication. That's the flow chart, and look at the number. It's a decent number, 96 patients. And we will randomize them. If you might notice here, there is no trial period. Even that, and that's a long discussion on this, even paresthesia-free, once you do a trial and then implant them, it will never going to be the same. It's not a truly double-blind study. Patient will be able to remember whether the therapy switched on or switched off, even with paresthesia-free, because when they have good pain relief, they start to guess and they said, no, this is not on, and it's not going to be truly double-blind study. So in this study, we remove no trial. The patient is fully implanted right from the outset with 2 implants, one epidural space and the second one subcutaneously, because we do not have implanted pulse generator to degrade itself. Nevro refused to do this. And the only way to go around this is to get the sham lead subcutaneously away from the spine. And we follow up the patient 1 month, 3 months, 6 months. And trust me, when it went to the technical committee, it was arm twist with them. They said, you put an implant and it is switched on sham control for 6 months. He said, at least at the end of the 6 months, the patient will have the opportunity to cross over to the active, and there is no surgery or anything like this. So we managed to persuade them. You always use my charm to make them happy. So we managed to do that. So that's the inclusion criteria. Per certain back pain, 60 out of 100. Pain detect to ensure there's some element of neuropathic pain. Degenerative disc on MRI scan, on stable medication. And exclusion, as you might can see, spinal to have a previous spinal surgery, spinal instability, widespread pain, and evidence of disruptive psychological or psychiatric disorder. This is the diagram to show where the leads are, the active one in the epidural space, and the second one in the sitting outside subcutaneously. And this is what looked like on the X-ray. This is the active lead. This is an AP and lateral view. And this is the sham lead completely away from the spine, sitting subcutaneously, because the patient will be able to charge their battery using a remote control, just like having an active therapy. And when they charge, because obviously that disperses any energy subcutaneously. Patient does not feel anything. So that's a truly sham control. This is the way we've done it. And we are going to replicate this methodology or other therapy. Nobody's going to escape. I'm going to do it on bursts. I'm going to be on DRG stimulation, and there is a long list to go. We need to finish everything in a nice way. No, hopefully it will be positive. We don't know. All right. We have the best university work with us: Oxford, Southampton, Exeter, Liverpool. We're looking into cost effectiveness of the therapy. We're looking now into also some of X-ray before and after. We're looking about TSPO, a number of things, because it is big study and we need to get a benefit. I'm going to just have a couple of minutes, please, because I know I run out of time. But I have to say about something, couple of the burst stimulation. Some of you, I'm glad to using this therapy. It worked very well. De Ridder published his first paper in 2010, and it was very effective. His thing, it is similar to nature way of stimulating, and very inspired by Gauti when designed Sagrada Familia Cathedral, and he thought this is going to be exactly the same. And this is the way it is. It is 5 spikes of high frequency, and it is firing and exactly similar with the thalamus. This is the form of conventional spinal cord stimulation, 1 spike, but when you compare it with the burst stimulation, it is non-linear burst, and it could be 5 bursting together, and it will stop and do it. Similar, exactly they're saying within the spinal cord. Number of studies been done before, and the biggest study, they done some burst. The outcome, it was okay. It's not as good as sensor study. There's some issue with the design of the study. They come and ask us, can you help us with this designing study? They said, yes, we can, and we done the CRISP study for them. CRISP study, it is this is completely different way of thinking. Usually when you do burst, and I'm sure some of you doing it, you wake up the patient in the middle of the operating theater and ask them where did they feel the buzzing sensation, and then in the recovery you burst. And we're trying to figure out, can we stimulate at T9, T10 independent from the paresthesia? The patient will be implanted 2 wires, one where you wake up the patient called paresthesia dependent, and then the other one, anatomical placing wire at T9, T10. And we're trying to find out, with the burst on these 2 different areas, would it make any difference? So that's the essence of the study. And it's a multi-center study with Leeds General, and this is the flow of the therapy. And the during trial period, 10 days on each lead. At the end of the period, we ask them, how do you feel? And we assess them. And at the end of the trial period of 20 days, we ask the patient which period you like, period 1 or period 2. So it's randomly, it could be paresthesia independent or anatomical location of the therapy. And these are the wires. The one we call PM, that's paresthesia mapping, and anatomical placement, that's T9, T10. Double blind for nobody we know. I didn't know. The assessor doesn't know. So truly double blind, and we 3 different programs. And this is the flow chart, and we managed to return 39 patients at the end. So it was a very good outcome after 1 year. And look at the trial period, 81 patients passed the burst stimulation. And there is no change, no difference between anatomical location or paresthesia mapping. So if you have a patient who would need burst stimulation, you can easily put it on T9, T10, and you can get very good outcome. You don't need to wake up the patient. But if you really, really insist and you like to do 2 leads, absolutely, no problem. It will cost you a little extra, and you can put the second lead from 7 to 8, and the second one to 9 to 10. And this is really the outcome. You can see significant reduction in pain in both leads, whether back and leg pain. So, and this is tornado outcome. The red one is anatomical, and the blue is paresthesia. And if you draw the line, we can see that it's 50%. It's not working now? Okay, 50%, that's the number of patients. But what really we found, improvement, 20 out of 42 patients a profound outcome. And a profound outcome defined as more than 80% by the impact group. Now, we looked at the quality of life improvement over the time, as well as patient quality of life at different aspects. And we're looking into also whether the patient there is any bias in the preference. And actually, there is no preference changes in order. So each order is completely exactly the same. So group 1, when you do paresthesia first and anatomical second, that's the change in the VAS score. And if the anatomical first and paresthesia, it is 60. So both of them, there is no significant in the order. Now, these are the video. Are you standing by? So this is toward, just like this is a very quick video. We are going toward objective measurement. Because we have such an active pain management program, we got subgroup of these patients. And we measure their activity, walking ability, before and after the stimulation, and we measure the, wait, okay. So that's before, the one before that it was crutches using, and we measure the number of meters over 5 minutes. And you can see how much improvement after the 12 months time. And this speaks volume when you talk to the patient. You show them the video, say, this is where you were, and look at you, what you're doing now after 12 months time. At least you're not asking, what's your VAS score? Because just something in you, something smart we're trying to do. And also we looked into ability to climb the stairs, a number of the stairs at a certain time. So that's before the stimulation, and this is after the stimulation, 12 months after the stimulation. And we looked into number of the steps they're making when they climb over 1 minute. It clearly says faster, there's no crutches, it's more active. And that's for them as for us to see that actually the therapy is effective. So, so the conclusion from the CRISP study is it clearly is effective, and it is, and now we are doing a bigger study on this. So, and that's delivery study. It is a multi-center, multinational study looking into substantial number of patients. There is big thank you to those people who work with our department and leads, and also the engineers at Abbott. They put a lot of time. So I am just going to stop a little bit around here. That's one of the things that we are doing for neck pain, called the new burst. This is stimulation for patients who never has failed neck surgery syndrome, or they never had surgery before. And we do use 2 leads staggered at around C3 and 4, and we're stimulating into this area. And we give 3 different programs around that area, and outcome is so far so good. So around 3 different programs around C3, 4. Still, we are in the middle of this study. Now, there's a lot of advances in neuromodulation, and paresthesia-free. We got new therapies, which is now without implanted pulse generator. We got different indication, but one of the things is never going to change. This is John Lawson concept of pain. All patient comes with a lot of psychosocial issues, and we should not forget this. And so still, as we said before, patient selection and education is the key of the success of neuromodulation. And this is our team, and thank you for your attention.